Now we'll try this. I believe we'd gotten down to auscultation, and we'd said we were going to use the stethoscope to listen for the sounds of breathing in lab. And so, inhalation is called what? Inspiration, thank you. And when you're listening to vibrations, what does it end up sounding like? Yes, because when you inhale, you're doing it more briskly than when you exhale, and therefore the air is moving briskly, vibrates longer and louder in your body cavities. So this is the longer, louder, auscultated sound, which leaves exhalation or expiration to be shorter, softer sound during auscultation. Then in lab, you are asked to listen to abnormal sounds of breathing. Abnormal sounds of breathing were called adventitious sounds. Adventitious sounds. So if it was mucus with air bubbling up through mucus, that is called rales. But we differentiate 3 degrees of rales. We talk about fine rales, medium, or coarse. And what that has to do with is how far up in your respiratory tree the mucus has accumulated. So if mucus is only in your alveolar sacs, then the air is only popping up through a little bit of mucus. That's fine rales. And if you've never heard it, if you take your hair-sprayed hair, so you're going to have to get friendly with some of the girls, guys, and do like this near your ear, that little crackly sound your hair-sprayed dry hair sounds like, that's about what fine rales sounds like. Medium rales that's when the air is up in your bronchioles, So it's having to bubble through mucus in the alveoli and the bronchioles. That is kind of like the blister pack you peel off the outside of a new DVD. It sounds kind of like that when you crinkle it up in your hand. Coarse rales, it's up in your bronchus, and that kind of sounds like chicken frying in deep grease in a pan. So that's a much louder sound. So it's congestion sounds is what rales is. We hope you don't hear any rhonchi. Rhonchi is sometimes nicknamed the death rattle because that is often a gurgle sound people are making when they're terminal and they're at the termination point. Wheeze, we talked about that when we talked about asthma. It's a whistle, and that's caused by 2 things. The inner membranes of your bronchial airways have inflamed, narrowing the lumen, the airway, and the muscle has constricted. So if you can't see the word constricted, so that's tightening the tube. So with the inner lining inflamed, and now you're tightening and lessening the diameter, 2 different things are making it a narrower opening, and that's why when you exhale particularly, you hear a whistling sound, and that's called a wheeze. Friction rub. Friction rub. We hope you didn't hear that. That's a leathery scrub sound. A leathery, scrubby sound. And that is caused because your pleural membranes, your visceral and parietal pleura, are infected, whether viral or bacterial infection. And so they become puffy and inflamed. And they're supposed to glide because they have a watery like serum that is secreted in those serous membranes known as visceral and parietal pleura. But when they're inflamed, there isn't enough lubricant there, and so the membranes grab each other and they're forcing themselves across each other, and that's the scrubby sound that you're hearing with that. That's a very, pleurisy is a disease that's accompanied by a very high fever, and it's a very dangerous disease. And with that friction rub, it's very painful disease. So those are abnormal sounds of breathing, adventitious sounds, so understand that. Now, I want to go back up here. When we were in your lab last week, we did this air volume. All these air volumes are cubic centimeters of air, so it is a volume of air that you're exchanging. And they use an adult male for this. Obviously, depending on your stature, your body frame size, these air volumes could be different. If you were an athlete for numbers of years, probably your heart is bigger than the average individual, and your air capacity is probably bigger. Your lung volume is probably bigger. But assuming that this is an average male, then when you breathe, like right now, you're breathing in, you're breathing out, until I just mentioned it, and now you're thinking about it, and you can't breathe right at all. Which is why we did not take this volume in the classroom, because the minute you're consciously thinking about it, it's an artificial volume now. But until I brought it up, all day long you were breathing in and out, and the same amount of air is going in as typically goes out when you're doing normal sedentary restful breathing like we're all doing now. Kind of like the tides coming in and going out, and coming in and going out. That is known as your tidal volume. So the other day on the movie, when you watched the guy working out, just sitting there before they made him start riding the bicycle, it showed a little blip, and it was the same amount of peak at the top as peak at the bottom. That was his tidal volume. So that's about 500 cubic centimeters of air. But if you go into the doctor's office and you're breathing normally, and then he's listening to you with the stethoscope on your dorsal surface, and all of a sudden he might say, take an extra deep breath and hold it. So you've already inhaled your normal tidal volume. You could, at his request, take a really deep breath. That extra air volume over and above the 500 cc's you've already inhaled is called your inspiratory reserve volume, IRV, 1,000 cubic centimeters of air. So we're capable of doing that. Now let's say you're back to breathing your tidal volume, 500 in, 500 out, 500 in, 500 out. You could then go, after you've exhaled your 500 cc's, and make some additional air come out of your body. That is your expiratory reserve volume, which you normally aren't pressing out of your body, but it's another 1,000 cc's of air that you could put some extra force against your thoracic cavity and exhale. That's exchangeable air volumes. So if you took your normal breathing, 500 cc's, tidal volume, and you added to it your extra deep breath, inspiratory reserve, and you blew out everything that's in your body that you can possibly blow out, then you're also blowing out your expiratory reserve. That volume is what we recorded the other day in class, because we said take your biggest breath, blow it through the handheld spirometer, and see how much you exhale. That is called your vital capacity, VC, 4,500 cc's for a male, for a typical male. And hopefully you were 70% or higher. Many of you were 100 or above. Okay, now, when you blow out all the air you can, still your lungs should not collapse. The reason your lungs should not collapse if you forced out your expiratory reserve after your tidal volume has left your body is because we always leave a residual volume of air in the lungs to keep them just slightly inflated so that the inner surfaces won't touch each other and it'll be easy to put the next puff of air back in there. That is called your residual volume, and it's 1,500 cc's of air. That is not stagnant air. Every time you breathe in your tidal volume, it goes down there and mixes with everything in your lungs, and so when you're exhaling, part of the 500 cc's of tidal volume is the last residual volume. So it's always just mixing and being replaced, but you leave 1,500 cc's usually in there. Now, it's getting popular again, I hear, kickball. You're out in the beautiful weather yesterday playing kickball, and the orange tree in the backyard is second base, and you're looking over your shoulder because you're wondering if they're fixing to get you out by hitting you with the kickball, and you run right into the stump of the tree. Then you might have been running really fast. That could have forced out a little bit of your residual volume. Probably not all of it, but a little bit of it. What do you feel like? You got your breath knocked out. That's what we talked about it. Is it uncomfortable? Yes, very uncomfortable. And eventually you'll recover and be able to finally breathe again and replace it. But it's not a natural volume of air that you want leaving your body, and so it makes you feel very uncomfortable when something like that happens. But normally, none of it leaves. Total lung capacity then would be how much air is in your lungs. And it would add to the vital capacity. In other words, this plus this plus this, vital capacity. It would add to that residual volume that you normally don't blow out. So those two numbers together add up to 6,000 cubic centimeters. So that's your total lung capacity. But then, you hear on TV all the time these sad little stories about little girls at prom, and they go into the ladies' room, and they deliver a baby, and no one even knew they were pregnant, and nobody certainly knew they delivered a baby. And they leave it in the trash can. Now it becomes a legal question. Did the baby take a breath or did it not? Because if the baby never took a breath and it was truly stillborn, then it didn't inflate its lungs at all. And now, yes, even though it's sad, and you would question that child's ethics that threw a baby away in the trash can, legally they're not in any legal problems because the baby was stillborn. They didn't kill anything. It was already deceased. But if the baby took a breath, that's a whole different kettle of fish. Now you're talking about the baby was alive and now abandoned, when there are places you can leave a child if you do not want a child. So if the child never took a breath, what forensics does, what they would do in the autopsy of that child, is clip off a little bit of the lung tissue, and if you put it in a beaker of water, it would sink because it never had an oxygen molecule in it. Whereas, remember the goat pluck I inflated last week? It's been inflated several different semesters. If I snipped off a piece of it and put it in a beaker of water, it will float. Because even though it's totally collapsed when I put it back in the freezer, so it's pushed out this residual volume, because when something's dead, the lungs do collapse, there still are molecules of gas clinging to the inside of the alveolar air sacs. So always a piece of that lung floats if you drop it in water. So if you took your fetal pigs you're dissecting today and clipped off the lobe of lung, it would sink, because they were taken out of the cow's uterus. They weren't born. Get my drift? So that little unmeasurable volume that makes lungs float is known as the minimal volume. So we won't give you a cubic centimeter reading on it, but it is, for forensics purposes, a tool that's used medically to determine the status of an infant when it's newborn and found abandoned somewhere like that. So you've got to know all these air volumes for a lecture test. The only one of these you have to know for a lab test is vital capacity. So if you need to mark that, that's the one you measured in lab with the spirometer. We briefly mentioned this word on the front of the page, but pneumothorax is when you get extra air inside the pleural cavity. What I mean is, you didn't get extra air inside the lungs, you got extra air in the space surrounding the lungs. That puts pressure on the lungs, and what are they going to do? Spontaneously collapse instantly. So I told you when you remove a chest tube, you can't crack it to the side and let air into the thoracic cavity around the edges of that tube, because if the air on the outside of the lungs exceeds the pressure of the air within the lungs, intrapulmonic is within the lungs, they're going to collapse every single time. So that's called pneumothorax. Air, pneumo, in the thoracic cavity. Okay, so we'll stop here on this sheet, and now we're going to start going over structures. So turn to the next page. We're going to start at the proximal part of this system and work our way down into the alveolar air sacs distally. So a major organ of the respiratory tract is your nose, and the nose has three functions, only one of which has to do with the respiratory system. In terms of your respiratory system, it filters air and removes debris, and you have hair in the beginning parts of your nose, but very quickly, when you get in your nasal cavity, it changes from keratinized tissue with hair to moist mucous membranes, in which case then the mucus is helping to entrap the dust or debris or insects or whatever that you might have snorked up, like a fruit fly or something in this building. But anyway, so once you get to the mucous epithelium, you move the mucus along towards your pharynx, your throat at the back of your nose and mouth, by way of cilia that beat towards your pharynx and down towards your esophagus and stomach. That is called ciliated, pseudostratified, columnar epithelial tissue. And the single cell on the far right here that has a vacuole that spits mucus drops out the top is called a goblet cell. So we mentioned that in lab, but in the larger airways, this is the standard tissue in your respiratory tract. Ciliated, pseudostratified, columnar epithelium. So in the back of your nasal cavity, extending up in all of your sinuses, then this is the kind of tissue you have. In your bronchus, in your trachea, this is the kind of tissue you have. You do not have this kind of tissue in your throat, which is your pharynx, because that's connected to the back of your mouth, and that's stratified squamous, because you're swallowing undigested food balls, a bolus of food, and it's scraping, so you can't have a single cell, a single columnar type situation, or you'd be down to the delicate underlying tissues. So, cleaning the air, whether due to hair or in most of the respiratory tree cilia. Warming the air. We talked about how close to the surface of your epithelium blood vessels are in your sinuses and your nasal cavity. And it brings the air that you are inhaling to with 1 degree of body temperature. Body temperature is 37. It brings it to at least 36, even if you're breathing very cold or hot air, by the time the air moves just into your pharynx, your throat. But let's think about that. Air doesn't go nose, pharynx. Air goes nose, nasal cavity, up into your paranasal sinuses, and then down into your pharynx. So if there's air already up in the sinuses, your new breath is going to push that air down into your pharynx. So it's been up there mingling against all your warm, moist tissues, is why it's able to be brought to body temperature. The one time this definitely will not work is if someone's caught in a fire. Because even if you're not where the flames are, if you're in close proximity, it can heat up hundreds and hundreds of degrees above body temperature. And so what do most people die of when they're in heat like that? They don't die of the flames. They die from passing out because they inhale that very superheated air. Your body can't bring it back down to body temperature, and it goes down and burns out your alveolar air sacs with one breath. And 1 minute later, what are you going to be? Unconscious. So you'll be unconscious. So, not that you want to sit around and talk about somebody burning, but if you had a patient and they just lost their children in a house fire, at least you could say they probably didn't feel anything because they probably were unconscious. That is at least a point of comfort. Moistens air, that's largely due to the mucus in the nasal cavities and sinuses and the rest of your respiratory tree. Of course, we want the air moistened because we don't want to dry out the single cell, very thin tissue of an alveolar air sac. So the moisturizing is an important thing as well. We don't think about that here. We're usually dealing with high humidity, and as we breathe, we're breathing nice, moist air. But if you've ever left subtropical Florida and gone out to Colorado, Denver, where it's high altitude, you have to put something like a glass full of water on the radiator because it's such dry air out there, it dries your whole respiratory tree out to the point your membranes will hurt and split and you'll be bleeding if you're not putting some kind of artificial moisturizer into your respiratory tree. Then you've got to put moisture out in the room so it will evaporate as the heat is operating. Another function of your nose is olfaction, so learn your vocabulary. That's the sense of smell. We think the sense of smell is very much like the sense of taste. Think about your brain and skull study last semester. You had a cranial case that your brain sat down in, a bony case, and up at the front of it, there was a bone called the ethmoid bone. Now, most of your ethmoid bone is between your fingers right here, full of 9 to 13 little honeycomb-shaped cavities, which we call your ethmoid sinuses, right? But the top of the ethmoid bone had little porous holes in it. That was known as the cribriform plate. Do you remember that? And what that was for is nerves of smell go through the cribriform plate, go from your nose up through the cribriform plate in order to get to your brain. And remember, you had the olfactory bulb and olfactory tract and the fornix, smell, those are smell tracts, and ultimately it's going to go back to your temporal lobe to be interpreted as various odors. Well, what they think is, since now you know that your nasal cavity is moist all the time, mucus, epithelium, whenever you breathe particles in, those are chemicals you're inhaling, they mix with the moisture in the moist mucus epithelium of your nasal cavity, and there are nerve endings hanging down there, dendrites. So if what you just inhaled was smoke, maybe only 2 of these nerve endings hanging down detect the chemical that is smoke. And so they would fire, and they'll send those impulses through the cell body, down the axons, up into your nose, and that will be interpreted as a smoky odor. How many of each neuron you have, nerve fiber you have, and what type is in your genetics, which might account for why one person likes a flowery perfume or cologne and somebody else likes a musk instead. All our distribution of nervous tissue isn't the same, and therefore how you're interpreting one chemical odor compared to another may be completely different than somebody else, and therefore your interest in the different fragrances is different. But it's all in what neuron you responded to that particular chemical. So in microbiology, you talk about bacteria that have a ratty odor. They smell like an old rat fur smell. Or fecal odor. We all know what that odor is. So we can distinguish odors due to which neurons are firing. All right? Then how come you can't smell your own cologne on your own body? And yet you walk up to somebody and they go, gosh, she smells so good. You hope that's what they say. Because you're firing the same neuron all day long. So you have fatigued it. It's used up its neurotransmitter substance, and it's not firing, so you don't notice it, or you notice very little of it on yourself, but someone else might notice it. And yet if you took your same cologne and you spritzed it on somebody else, you would probably smell it because it mixes with their body chemistry, and their body chemistry is a little different than your body chemistry. So now when you smell them, it's probably a different neuron that's firing because it's mixed with different chemicals in their body.
Do they recover?
Yeah, they do, because I mean, you bathe and now you're not firing them, you know. So I'm not saying they're not firing at all, because you could probably smell right where you applied your cologne and smell it a little bit, but you're just not noticing when you walk around the room that you have this little fragrance trail following you, but everybody else can, and it's because you fatigued those neurons. At least that's what they think is happening. Okay? And of course, that's one of the things they tell you if you're going into an area of patient care. You have to be very careful about fragrances, because people on anesthesia, that can make them very nauseous if you come in with heavy fragrances on. or really bad is cigarette smoke. You walk in, you've just come off your break, then somebody who's already feeling goozy because they're half under anesthesia, but you could just set them right over the edge and make them ill. So they suggest you not do heavy fragrances when you're in that field. The other thing your nose has to do with is speech. Now, not so much can you make a consonant and vowel sound. That's in your mouth with your tongue, etc. But what we call tone quality, or some people call it timbre, or resonance. You know how if you go listen to a band somewhere and it's got really good acoustics where they threw the concert, then they sound like themselves on a recording on the DVD or whatever. But if you're listening to them somewhere and there isn't good insulation, they just sound hollow and tinny and don't even really sound like themselves. That's what resonance or timbre is, tone quality. And the shape of your nasal cavity is going to make you have certain tone quality to your voice. And they say, unless you were an identical twin, that there should be no two people whose voices should be identical due to things like the shapes of your sinus cavities and your nasal cavities, etc. In almost all the other countries of the world, they believe that to such an extent. In their legal law courts, they will use tape recordings and be willing to say, no, that's not this person's voice. But in our country, they still won't break down and allow recorded things for just in case there's a mistake. But anyway, we'll come back to speech later when we get to the digestive tract and say a little bit more about that. Paranasal sinuses, you were to have studied in Anatomy 1. You're looking at them again right now on the green plaque that showed the sagittal and frontal section of the head. But you have two sinuses up here. All of these drain indirectly to your pharynx, to your throat. But you have two frontal sinuses up here. That's why if you get sinusitis there, a sinus infection there, sometimes you suffer from a headache. You have two of them right here in your upper jaw. Your upper jaw bones are your maxillae. Some people have a toothache if they get sinusitis inflaming those sinuses. You have a cluster right here. Some people that suffer from that kind of get blurry vision. They get a sinus infection there. And behind that ethmoid is one big sphenoid sinus. They are also lined with the moist epithelium that was called the ciliated pseudostratified columnar epithelium. So you got moisture. This is inside your skull. This is at body temperature. What better place for a single-celled organism to survive than in a place that has moisture all the time and a regulated temperature? Therefore, we have a real problem with infections from there. And that is called sinusitis. And it could be infected by bacteria. It could be infected by fungi. It could be infected by viruses. There's a fungus that can grow so aggressively in the sinuses of your skull, it can spontaneously break your facial bones. So they literally have to go into your sinuses and pull that fungal infection out if you're identified to have that. A lot of people who think they have TMJ, temporal mandibular jaw dysfunction, and they think that's what's making it hurt for them to chew, and you can hurt so bad you can't bite a piece off of a carrot, a small carrot stick, or you certainly can't take a chunk out of an apple, but even when you slice an apple and you're trying to bite it, these people that think they have TMJ are hurting so bad they can't make themselves crunch down through an apple, they're hurting so bad. A lot of times you don't have TMJ. You have a sinus infection. Your sinuses are right there next to that joint, so when this is inflamed, you think it's your jaw that's making you hurt to chew, but instead you're just so inflamed that so your doctor will tell you take something like a Claritin or a Zyrtec or something like that to get the inflammation to go down to dry up your sinuses. you should listen to them. They might be right. Wouldn't it be nice if that's what's wrong with you and not that you're going to need some kind of appliance for TMJ problems for the rest of your life? But a lot of people suffer from that, especially if you're in the allergy season and you're one that suffers with postnasal drip and things like that, then you could very well be one of those people. If you do truly have TMJ or this, they say don't stretch your mouth. People think, oh, well, let me just open my mouth really wide. That just aggravates it if you've already got swelling. So you're supposed to baby it until it goes down. But anyway, you can ask your doctor to look and see if it might be sinus related. They usually know pretty quick just by looking at inflammation as they look up your nose, scope your nose and all that. We have the sinuses, yes, to warm and filter the air because it percolates through all those spaces, but also to lighten the bones of your skull. If bones of the skull are too heavy, they would mentally retard your child. So you need light bones that are protecting the soft nervous tissue that we call your brain and sense organs, but you don't need dense, heavy bone because that could mentally retard you. Okay, pharynx is your nose, and is your throat. And that influences speech too because there are muscles associated with your pharynx, and therefore if you change the shape of it, that's going to also influence your speech patterns. We talk about 3 regions of the pharynx. The uppermost part is behind your nose, so that's called your nasopharynx. And there is an orifice that dumps in there from your middle ear that you studied last semester called your eustachian tube. That's from your middle ear to the pharynx. But that's in your nasopharynx, so you have one from each ear. If you have pharyngitis, you have a sore throat. If you have pharyngitis, your kid is very quickly fixing to probably have otitis media, a middle ear infection, because it'll go right through the eustachian tube and land in the middle ear. You hear a lot about this area when you have bottle-fed babies, because if you don't hold your baby right and you let them drink, then they've got their head tilted back. And as we age, our eustachian tube becomes more diagonal and it drains better to our pharynx. But when you're young, it's a little more horizontal, a little less diagonal. And so if you position them in the wrong position, like laying them flat on the bed and nursing them, not that you're not so tired you haven't done that a few times, but anyway, then the nourishment can go right through that eustachian tube and end up in the middle ear. The middle ear is supposed to be totally dry. That's where the little ear ossicle bones are. And so then they get a middle ear infection. And if you got a baby that stays with middle ear infections over and over and over again, what does your doctor recommend you do? Put a tube through the eardrum, through the tympanic membrane, to let the middle ear drain out and dry out to the external ear. And usually those tubes work their way right through that eardrum and fall out. But this is a major route of infection between your throat and your middle ear right here. Some kids suffer with it really bad, and other kids don't seem to have as much of a problem with it. Oropharynx, well, your mouth is your oral cavity, so this is your throat behind your mouth. When you're opening up to see if you have tonsillitis, you're looking at your tonsils at the back of your throat. You can't see your adenoid pharyngeal tonsil. You can't see your lingual tonsils under your tongue. You know, I just need to remind everybody to take a break before you come in here to lecture. I know you might have grabbed a quick bite of lunch or something between lab and lecture or whatever, but please, we need to slow down the traffic in and out of here. So take your personal breaks before you come in here to lecture, please. As you go further down the pharynx, so this is just one tube, then you're leading up to your larynx. Therefore, when you're below the oral cavity but leading up to your larynx, that is called the laryngopharynx. the laryngopharynx. So see, if this is the front of your body and this is the back, this is sticking up. So it's sort of the throat leading right here, they say behind the larynx, but it's only behind this portion. It's not inside the larynx. Now, let's talk about this pharynx. It has 7 orifices that communicate with your pharynx or throat. 2 nares. When they're communicating with your throat, you're at the back of the nasal cavity, so those are called internal nares. These are called external nares. So it's like a tube, a hole at this end and a hole at the end that's going into your throat. But you got 2 nares, so you could get infected that way. Got 1 fauces. Well, if you're in your oral cavity, you're in the mouth. But if you want to leave the mouth, you go through that heart-shaped opening that looks like this. That hangle-dangle like Olive Oyl and Popeye when she's screaming tied to the railroad track. That's a uvula. That heart-shaped opening is all of this space right here. That's called the fauces. I could not spell it. F-A-U-C-E-S is this space in there. So it's where you're leaving the oral cavity going into your oropharynx. 2 eustachian tubes, we've mentioned those. Those enter the nasopharynx region. Now you got 2 choices down because this pharynx is fixing to split. So if you go the airway, you're taking the larynx. If you go the food way, you're taking the esophagus. So any of those are possible infection routes. Okay, let's talk about the larynx. We'll come back to this picture in a minute. Larynx, in common everyday talk, is your voice box. And it's only larynx once you're above the C-shaped cartilage ring. So you've got to see the dark gray quit, and then you're in cartilage that goes all the way around. Now you're at the larynx. Remember, blue or gray is cartilage, white is bone. So this is your hyoid bone right here. Most of the cartilages of your larynx are the same type of cartilage as your tracheal rings, hyaline cartilage, like the tip of your nose. That's hyaline cartilage, with 2 exceptions, and I'll get to those. Now, this is half of a thyroid gland. The other half would be a lobe over here. So as it grows, it kind of segments like 2 butterfly wings. When you looked at your pig today, it just looked like one mass in the middle, but you've got to remember that's an unborn pig. It hadn't really segmented into the 2 separate blobs yet. But anyway, because that's your thyroid gland, this big cartilage that thyroid gland sits just inferior to is called your thyroid cartilage. So they call it the biggest and shield-shaped cartilage, large shield shape. So that's what I'm representing right here off of a computer depiction. This cartilage right here, when you swallow, your tongue's supposed to do this, retract back like that, and so the base of your tongue hits this flexible cartilage and flips it down over your airway to protect you from moisture or rice or bread or food going down that airway and causing you to choke. So this is an elastic cartilage because it needs to be very flexible. So that is one of the exceptions that is not the typical hyaline cartilage. And it covers a hole, a slit called your glottis. Your glottis. When you look down in here, do you see this white gauze? I'm going to put my finger in between the white gauze. See the white gauze? That's your true vocal cords. Vocal cords aren't strings like harp strings. Vocal cords are like 2 blades of grass. Did you ever grab 2 blades of grass when you were a kid and put them between your fingers and go and make it whistle? That's how your vocal cords work. So this gauze is your vocal cords, and where I just stuffed my finger is in the hole that is called the glottis. And so literally this epiglottis is blocking your glottis opening, so things can't go down in your larynx. Okay? So it says it covers your glottis, the slit-like opening. So I've drawn you the slit right there. Yes?
What happens like when people do soak food down?
Well, theoretically, they go, well, you're talking and chewing and eating at the same time. Because if you're talking while you have food in your mouth, you can't make sound unless this epiglottis is open so that air can go through the vocal folds or vocal cords. In which case then, if you swallow a little bit of rice or something, then you're likely to get choked. I'm sure there's somebody that's had that mistake happen though, even when they weren't talking. So I'm assuming that it doesn't always land true. Maybe it gets pushed over to one side or the other because it's something you were doing with your tongue or whatever, I don't know. But you know what I'm saying? But that's what they say, is we shouldn't talk and eat at the same time. However, if you're elderly, once you hit 45 or older, some people get a sluggish muscle peristaltic activity in their pharynx / esophagus. Theoretically, that picks up in your esophagus, but even your pharynx gets a little sluggish. And a lot of people self-diagnose themselves and say, oh, they have a hiatal hernia and they have a constriction in their food tube. But a lot of times it's just this muscle thing that happens with age, that it's not as quick responding and you have trouble swallowing. And so you have people that get cough attacks in the middle of a meal, but it's because the food's not going down. So they feel like they have to drink a whole bucket of water to get a dry sandwich down as they get older. And so they opt not to eat that kind of thing as much, because it can be really, really dangerous if you're on your own and it's just not moving. And you think, oh, it'll do better, let me just soften it up and swallow extra fluid. That just makes it worse. Yeah, if you have that problem, you have to eat little bites at a time, very little bites, and stay away from things that you're not getting along with, especially if you're eating on your own by yourself. Because old age is not for weenies, apparently. Okay, so we got the big thyroid cartilage. There, and we've got the elastic cartilage called the epiglottis. There is a cartilage that's like a big class ring. You know, your class ring had a big jewel on it, but it's like the class ring is turned around on your finger backwards so that the jewel's on the back side, not the front side. See, this is skinny in the front, but then you go around to the back and there's the big old jewel back there. That one's called the cricoid cartilage. The cricoid cartilage. So that's the inferior most. So there I'm showing you the back view. There's the jewel on the back side. Then above, so we're on the back now, looking at it. So there's your big cricoid cartilage I just showed you. Then there's two cartilages stacked up right on top of that. This one right here looks like a little piece of candy corn. I like that description because the name of it is corniculate cartilage. This big one down below it is called the arytenoid cartilage. So you have two corniculate cartilages, I've shown you them, and two arytenoid cartilages, and that's from the pointer down. So I've shown you that on this side. Those are all hyaline cartilages. Now the other two are not depicted on this model, so you will not be asked the other two on there. But there's two more little tiny cartilages, which quite frankly, when I showed you the pieces of gauze, it's embedded in the gauze vocal cords or the vocal folds. These are elastic as well, they're flexible, because they influence the tension on your vocal cords for pitch of sound, high sound and low sound. They are called the cuneiform cartilages, but they're not on the model. Just know that they have to do with pitch of sound. How do they influence pitch of sound? Because they change tension on your vocal cords. Men, when they go through puberty, a lot of men, right here, their thyroid cartilage will become more triangular shape, and it slackens the tension on their vocal cords, and that deepens their voice. So that can happen with men going through puberty. This is called the laryngeal prominence, but in common everyday terms, it's the area that you call the Adam's apple that's so prominent in men. Are we okay? So know those 9 cartilages that make up your larynx. 1, 2, 3, 4, 5, 6, 7, 8, 9. You okay? That whole thing is called what organ? Larynx. I need to do trachea, and then and a couple other things, and then I'll go back to that other picture. Your trachea is your windpipe by definition, but it's called trachea. All of ours aren't identical. We do have C-shaped rings of hyaline cartilage to keep it open all the time. It doesn't have cartilage on the backside because your esophagus has to expand into it when it's full of food. But here's the difference. You all have somewhere between about 16 or 20 C-shaped cartilage rings, tracheal rings. So we all don't have the same number. Your trachea is about 4.5 to 5 inches long in an adult and about 1 inch in diameter. When you run out of trachea, you're not to the lungs yet. You've already split before you got to the lungs. So the tubes that are entering your left and right lung are a left and right primary bronchus. So know at least left and right. They have random patches of cartilage, as you saw in lab under the microscope, and that is hyaline cartilage. So the right primary bronchus is more vertical and usually wider and therefore more prominent than the left one. Who cares? The reason you would care about this is because when your little kid swallows a button, or worse than that, a battery out of your phone, the little disc batteries or whatever, where are they going to go look for it first? Down the bigger right bronchus that's vertical, then the skinnier and more diagonal left bronchus. Of course, you know, when they were doing bronchoscopy earlier, we didn't have imaging. Now you've got so many imaging tools to use. They probably would have that kid imaged so you'd know, yes, it did go down the right side and it's sitting right there, and then they'd go after it. Some guy was eating green peanuts. He didn't boil them to make boiled peanuts. He was just eating green peanuts, and he aspirated one and sucked it into his lung. It's body temperature. It's moist. The darn thing sprouted. And so this guy was saying how ill he was for months and months and months. He couldn't get over what seemed like some kind of pneumonia or something bothering his respiratory system. Finally, they did imaging and saw that he was growing his own little
peanut.
Yeah.
This
Yeah.
happened up north with people breathing in seeds from trees and growing actual trees inside their airways.
Wow. Probably because there's a lot of farming. Yeah, they're disking up stuff. Yeah. They also have a lot of fungal indigenous infections up there for the same reason as they're turning that soil over. You don't think about, you would think it would be very healthy to be a farmer, but you know, breathing all those things that grow in that damp, fertilized soil. Okay, and you are we call it primary bronchus if you're going to the left side, left lung, or the right side. Once you get to the lungs, remember they have divisions, and so that's why we talk about secondary and tertiary bronchi. I'm not going to test you on this, but if you're curious, let's say I went to the right lung. How many lobes are in your right lung? 3. So you'd be 3 secondary bronchi on that side. How many would you be on the left side? 2, because there's only 2 lobes on the left side. And then when you branch further, now you're a tertiary. But you definitely go from 2 to go to the left or right, down to 5, 3 to the right and 2 to the left. That's secondary. And then you branch further to become tertiary. But just know bronchus, and I'll be happy on that. Now, you're not usually going to have cartilage anymore. So tell me what kind of tissue lines an alveolar air sac where you're going to exchange gases? Simple squamous, the thinnest cell there is. But what kind is in your larynx and your trachea and your bronchus? Ciliated pseudostratified columnar, tall, and we're going down to flat. So somewhere between tall and flat, we had to get stubbier. So when you're in the terminal bronchiole with no cartilage, it usually is still ciliated pseudostratified columnar epithelium. But who are you becoming next? A respiratory bronchiole. Now you're cuboidal. with no cilia. Because who comes right off of this but your alveolar ducts with your alveolar sacs, and they're simple squamous. So this is why you were transitioning from tall down to as wide as you are tall, cuboidal, and then this is an alveolus, your simple squamous, so that you can exchange gas. Okay? Now let's go back to the previous page for a minute. So, larynx and trachea, we know that. And see, long before you enter these lungs, you're not a trachea anymore. You're a bronchus. So when you see the baby blue tubes in this model, what are the baby blue tubes?
Bronchioles.
Some kind of bronchus. Bronchioles do not have cartilage. Baby blue is hyaline cartilage, okay, or some kind of connective tissue, but that's a bronchus of some type, okay? So, which lung is this? What do you call this lobe? Superior lobe. What do you call this lobe? Middle lobe. What do you call this lobe? Inferior. This is the left lung. It has no middle, so this is superior and inferior. And these are pulmonary arteries. They're dirty blood. And these are pulmonary veins, clean, returning to the heart. This is your aorta and your esophagus. There's your spinal cord. You okay on this model? What would be the membrane covering this lung right here? Visceral pleura. What would be the membrane lining the inside of your rib cage? Parietal pleura. If I said this is a space that's largely filled up with your right lung, but name what the space is, just this space, what is it? Pleural cavity. But if I said, what is this space down the middle that includes your artery and your vein, aorta and vena cava, and your esophagus and some glands, what is this space down the middle? Mediastinum or mediastinal cavity, yes. But what is this whole cavity collectively called? Thoracic cavity. What is this cavity that only has your heart in it? Pericardial cavity. You know what you're doing? Okay. So this diagram is trying to remind you of some of that and add one or two extra things. So here you see this has to be right because there's 1, 2, 3 lobes and they're labeled for you, and if the eye is not printed dark enough, then make your eye for the inferior lobe a little darker. But and then on this side you just have 2 lobes, so they are superior and inferior. So if you need to make a note of that, then go out here and say it. But the heart in the human body is shoved into the left lung much more than the right lung. So it creates a dent in the left lung. Therefore, that dent is called the cardiac notch. So you see that shaded in there very nicely. Now, there has to be an opening so that these airways, I'm talking bronchus, can get into your lungs. The opening is a little slit, and we've had a name for little dents before. That's called the hilus. The hilus is the dent or slit through which you come and go from a lung. But we don't just want the lung hanging on the bronchus like your silk blouse is hanging on a hanger, because it could slip off, just like that silk blouse slips off that hanger all the time. So this has to be attached. The attachment there, just like attaching grass into your backyard, is called the root. The root is the attachment. So if it's talking about an opening, that's the hilus. If it's talking about an attachment, that's the root. This is your apex of the lung, the peak of your lung, and the significance of that is that's the most highly oxygenated area of your lung tissue. This is the base of your lung. The base of your lung rests against your diaphragm muscle. You feel better with this picture now? Okay. I hope you took apart mannequins. You do have tomorrow night at 5 o'clock with Jared Jacobs, so that you know the difference between a trachea and an esophagus, etc. Okay, now we're done with the basic anatomy of this system. Let's talk about the functions of your respiratory system. There are three. Obviously, the first one is by far the biggest function. It plays a role in the exchange of respiratory gases. We're hoping to get CO2 out of your body and oxygen into your body. This is the kind of oxygen your body wants. It's called molecular oxygen because it's two atoms of oxygen bonded together in a molecule. There is O3 in the atmosphere. That's called ozone. There is also plain O out there, but this is the type that your body is looking for, O2. Now, when you exhale, you're exhaling the CO2, but you're also exhaling water vapor, and you know it on a cool day when you fog up your mirror in your car as you put on your chaplet medication or whatever. So, if you are exhaling water, with every water you exhale, you're getting rid of 2 hydrogen ions, and so that is helping to get rid of excess acids. If I am an asthmatic or anything that is a COPD, chronic obstructive pulmonary disease like emphysema, then I don't exhale too well. Therefore, I'm not getting rid of all this. If you keep this, it won't stay in its gaseous form. It'll go back into your bloodstream, and in your bloodstream, this reforms H2CO3, which is what this says over here if it's too little for you to read. And then H2CO3 doesn't stay in that form. It then comes back apart as one H by itself and the other H still bonded here. Well, this is a blood buffer called carbonic acid. This is a blood buffer called bicarbonate ion. So neither one of those things by themselves are doing you harm, but the more of this that you have, then a few of its hydrogens can come off like that. That is doing you harm. That's making you acidic. So someone in a severe asthmatic attack usually is running acidic. And being acidic is not a good thing because it inhibits your nervous tissue. So in the extreme condition, it could put you into a coma. Another thing that your respiratory system does is, because you are exhaling water, it does influence water balance. That's one more way you're losing water from your body. And water carries with it heat, as you learned in Anatomy 1, so it's helping you to control your temperature as well. Okay, this isn't respiration. That's ventilation. We'll get to that in a minute. There are two kinds of respiration that go on in your body: external respiration and internal. External respiration is what happens with your lung. You are exchanging between the lung capillaries and the lung air sacs, your alveolar air sacs. So you breathed in, the air is down there in your alveolar air sacs. Now it's got to diffuse over into the capillaries around your lungs. That's external respiration. So what do we hope is happening during external respiration? We hope that oxygen enters the blood, and we hope that CO2 exits to the alveoli, the air sacs. That's what we hope is happening in this stage. Okay, let's say everything did what it's supposed to. So now you've got blood that's leaving the lungs with high oxygen and a lower amount of CO2. So now where's the blood stopping next? In your active tissues, in the tissues that have depleted their oxygen. That is internal respiration. That is exchanges between your tissue cells and your blood capillaries. So when we're doing internal respiration, we hope oxygen goes to the tissue cells, and we hope that CO2 goes to the capillaries. At each place, we're trying to move the CO2 into the export route. Now, the reason we have the problems that we have, in other words, the two gases, CO2 and water, that we have to exhale, is all about our use of food. This is food. C6H12O6 is glucose or dextrose sugar, two names for the same sugar. In the clinical environment, they tend to call it dextrose, but in science classes, they call it glucose. That's your body's #1 favorite food. First choice food, if you have any available, it's going to be glucose. Look how many carbons are in glucose, 6. The way you do not create energy. The energy for us to move or change or grow comes from one and only one molecule, adenosine triphosphate, ATP. That's your energy for work. This is called food energy. We can't use it yet. But what you have to do is get the energy out of the food and create, using that energy, the bond energy to make ATP. So we're just converting energy from one form to the other, from food into usable energy of work, called kinetic energy. Well, so what do you have to do to the food? You have to break all carbon-to-carbon bonds. If I don't have any oxygen in my cell, I can break glucose, but only in half. So if I only broke it in half, I end up with 2-3 carbon chains. I didn't get very much energy out of that glucose if that's all I do, okay? So that is why I need oxygen, because if I have oxygen, I can break each one of these 6 carbon-to-carbon bonds apart. Every time you bust a bond, you get a burst of energy. And that's the energy that your body cells are using to put this bonded to this to make that. Okay? So it's all about getting our energy for work, is why we have to have a respiratory system to bring us in oxygen constantly. Because you won't break all the food carbon-to-carbon bonds unless you have oxygen there all the time. This little symbol, right now, this phosphorus is not bonded to something carbon-containing. This is a carbon-containing molecule. This is an organic molecule, therefore. This is inorganic, because right now it's a PO3 or PO4 group. So the little I under there means inorganic phosphate. So that's how they write it when it's just floating independently in your body. Don't let that throw you off. So this has 2 phosphate groups, adenosine diphosphate. When you hook the third one on, that's when it becomes kinetic energy, called adenosine tri, 3 phosphate groups, phosphate. So if you were in an active cell, we would be delivering oxygen to the active cell, and hopefully the cell would be doing this and coming up with this as a result. Okay? And then the problem comes if we got to then take these scraps back to your lung and get rid of them. We'll show you how we do that eventually too. So far, so good. You okay? So now we're talking ventilation. This is ventilation. Exchanges between the outside air and your respiratory airways. That's ventilation. Where will gases always move, or what will they move according to? Pressure. But what's the rule about pressure? High to low. When something moves from high to low, that's a gradient. So this is a pressure gradient. So air is always going to move from high pressure to low pressure. No exceptions ever. That's why I keep beating you over the head with what is the standard pressure out here in the atmosphere. Standard atmospheric air pressure is 760 millimeters of mercury at sea level, and we're pretty much at sea level. So then, we did this in lab very quickly, but here it is spelled out again. When you're doing inspiration or inhalation, and right now we're talking gentle, restful breathing, like when you're sedentary, that's called costal breathing, costal. Then the muscles that you're using are just two. External intercostals, which are attached to your ribs, and they pull your ribs up and out. So in your diagram, we show your ribs going up and out. That's your external intercostals. And then your diaphragm at the same time contracts and it bows downward. So what happens to the size of your thoracic cavity? It got bigger. And so if there's air trapped around these lungs, what happened to the air surrounding the lungs? This air that's trapped in here, what happened to the pressure on it? If I move the bones away and I move the diaphragm muscle away from it, the pressure lowers. And so it lowers to something like that. Well, if it's 760 out here and now it's 756 in here, which way is air going to move in your respiratory airways? In. And so it moves in, and so it's going to go all the way down into your lungs. And so what will the lungs do? Inflate. But it's all about that air pressure story. We're talking in normal sedentary, which is called costal breathing. Now there's only one muscle that contracts when you exhale. Down here. The diaphragm just relaxes. The diaphragm just relaxes. It tells you that over here. Diaphragm relaxes. So it's bowing back up. But what's the muscle that pulls down and in on your rib cage? Not external intercostal, but internal intercostal. So it's going to pull down on your rib cage like this. What happens to the entrapped air now? The pressure increases to something like 764 or 762. Well, it's 760 out here. Now which way does air move? From greater to lesser, so it moves out, and so your lungs deflate. But you only have one